will be live stream. So yeah, thanks. Tonight we're going to have a bit of a chat about lymph therapy and some of the rehabilitation issues with regards to breast cancer. I've also got a new colleague with me tonight, as you can maybe see, Dr. Andre Vos. Lizanne, our resident oncologist, is expecting her first baby any day now, so she's taking a little bit of leave. And he's going to be taking over from her, and yeah, if he enjoys working with us, then he might sort of stay with us. So yeah, we'll see how it goes. So without further ado, maybe Jennifer, I'm going to put you in charge. You can maybe introduce yourself, and then yeah, give a bit of feedback of who you are, what you do, and then from there we can take it further. All right.
Great. Well, hello everybody. I hope that you can hear me. I unfortunately had to be at home this evening. It's complicated with little ones, but it's really nice to be with you. Yeah, we were so excited to join the Paxo team, and in a few short months, I must say, it's really become a family. So myself and my colleague, and we've just had a new colleague join us yesterday. So the three of us make up the rehab team. And cancer rehab is something that's really growing worldwide, and I'm looking forward to chatting about it tonight. I like being informal. I like engaging. So this is not my choice of platform, but yeah, we'll try our best, and I hope that you can ask questions and that I'll pick up on them as we go. Yeah, but that's what we'll chat about this evening. I don't know if we should get started.
Yeah, I think, Jennifer, we can. I think if people want to join, I'll admit them as time goes along, but I'm quite happy that we start. All right.
Okay, so I've got a little presentation, and let my technology find it here quickly. Okay, so before I start, I just I've got the three little logos here, and pink and steel is an international cancer rehabilitation organization, and they've really helped us with the cancer rehab journey, and as we grow and as we learn, they've sort of held our hand. So yeah, just a lot of what we'll discuss tonight will be from them. So I just wanted to say thank you. So this evening, I was asked by Marlize to choose a topic, and wasn't entirely sure where to start, because there is so much when it comes to cancer rehab. And so I thought, let's start with the basics. Let's start with what I see in my practice most often. And I've named tonight's talk "Getting Back Your Mexican Wave." And that's really looking at, from a physical perspective, let's get back to moving, and from a more spiritual perspective, nothing says you're in a good mood and life is great than more than a Mexican wave. So I think it's the perfect picture of where we want to end up. I'm happy to speak Afrikaans, so if anyone wants me to translate or change, but I thought let's chat in English tonight for those who maybe maybe don't understand. So tonight I really want to discuss swelling and scar tissue related to breast cancer treatment. And this is something that I see a lot of, obviously being on the rehab side, but I think it's something that is also quite common and can be quite concerning for you as the patient and in general. So I thought, let's jump right in. And one of when I was doing research, one of the statistics I found was that up to 40% of women who have received treatment for breast cancer will experience chronic swelling. So 40% is a huge number, and this percentage comes from the UK. In the UK, they say that 40% of women getting breast cancer treatment will actually end up with a long-term problem with swelling. America, they are looking at about 35 to 40%, and in South Africa, the consensus tends to be that we are closer to 20%. And I don't know if that's because of maybe a different way of approaching treatment, or if it's simply because we're not logging the numbers. But that I don't know. But this is a statistic from the UK. So what is chronic swelling? What is long-term swelling? So long-term swelling, I'm sure many of you have heard that ugly word, lymphedema, and many patients come into my room and say, please, the only thing I don't want is a big fat arm. And a big fat arm comes from damage to the lymphatic system. So before we can look at a big fat arm, we have to look at what is the lymphatic system. The role of the lymphatic system is to gather fluid from tissue spaces and return to the circulation. So basically, all that fluid that sits between our cells that needs to be there, that's there naturally, gets taken back up into the body so that our body can deal with it the way it's supposed to. That needs to be done by the lymphatic system. The other thing that the system does is it helps to transport. It transports all sorts of good and bad things. And one of the big things that we often speak about, often look at, is bacteria. The lymphatic system is essentially your garbage disposal, and as we've seen during COVID and lockdown, if the garbage trucks don't come because there's too many guys unavailable, then we have this heaping up of trash. And inside the body, that's not a nice thing. That's not something we want. And then the other role of the lymphatic system is that it's our defense against bacteria and infections. The lymphatic system plays a really big role in immunity. And so I'm sure you all know, when we're having chemotherapy, one of the big things our doctors are always looking out for, that are always worried about, is how's the immune system functioning, and we're told to stay away, don't get a cold, try and stay away from people who are infected with something, because the immune system is not working 100%. And this is all linked to the lymphatic system. That is lymphedema. So lymphedema is if we're looking at the textbook definition, lymphedema is the accumulation of protein-rich fluid in the tissues from a impaired lymphatic system. So basically, when the system's not working well, we see that it becomes overloaded, it becomes stressed or panicked, and then those protein-rich fluids are unable to leave the body as they should. And it can affect any part of the body, the arms, the legs, the face, even the genitals. And in the case of breast cancer, we most often are seeing it in the arms and the breast, and in some cases around the chest area. And this is a really nice picture. That's what your lymphatic system should be doing. We've got all these vessels that run up the arm and run out of the breast, and they're accumulating in those little things that look like beans. Those are your lymph nodes. And the lymph nodes are then sending that fluid in the right direction so that it can be reabsorbed into the body. So you can imagine when you've had some type of surgery where they've removed lymph nodes, or even if you've had a mastectomy, that beautiful highway is disrupted. So it's like a car accident in the middle of the highway and nothing is moving as it should. And that's a problem, because if the highway is blocked, how does the fluid move? How do we get it out of the arm or out of the breast? And this is just a picture. Sorry, it seems a little bit blurry, but it's a picture of, this is actually a before and after picture, but this is a picture of a typical lymphedema arm. And some of you may have experienced it or seen it. I know many patients say they've seen it in the chemo room. So this is something you may have seen. And that, as you can imagine, causes big problems when it comes to moving the arm, putting on clothing. It can be quite stressful because it stands out, and we don't want to have this big fat arm. And that's a really that's quite a drastic picture. So that's someone who probably hasn't been looked after, hasn't had treatment, and the arm can eventually look like that, and we don't want that. That's what we, as part of the rehab team, are trying to prevent ever happening. Oh, that picture is also a little bit blurry, but that's also a lady who didn't get treatment, wasn't seen or assisted, had no rehab, and that's a couple of years down the line where she's actually not able to do that much with that arm anymore, and that's sad. That's not a picture I like to see, and again, we don't want to get to that point. So here's another fact for you. A large proportion of women who have had radiation therapy will experience radiation-induced fibrosis. What is radiation-induced fibrosis? It's just a very fancy name to say that you have got scar tissue as a result of your radiation treatment. And this scar tissue can be quite mild, or it can actually have quite a big effect on your life. So in addition to treating cancer, radiation therapy will change the way the tissue looks, the way it's put together, and the tissue can become thinner, it can become harder, and it can become more brittle. And when we talk about tissue, we're talking about, my focus is soft tissue. So that is your skin, your breast, and sometimes even your muscles. And radiation following surgery can change the scar and make it harder and denser. It can also cause scar tissue around the scar. And there's different things that influence the amount of scar tissue you might have, and that's got to do with the type of radiation that you have. And radiation fibrosis, or the scar tissue that you get especially in the breast, can be quite scary, because many patients say to me, but do I have another lump? Is the cancer back? Because the scar tissue can often feel like a hard lump in the breast, it can be disconcerting. It can also cause you to become quite stiff in your chest, and this can make, in severe cases, can cause problems with breathing, but it affects femininity, it affects the way a bra fits, and it affects the look of the breast. It can also run up into the shoulder and affect the shoulder muscles, and this can be very uncomfortable, and it decreases mobility, and that's the point where we're seeing patients come in and say, you know what, I was doing great. After my surgery, I could reach up and brush my hair, but now a couple of weeks down the line, I'm finding that I can no longer lift my arm. And again, this is something we don't want to happen, we don't want to see, and we want to sort out as quickly as possible. And there's a picture that's not a very severe case. This lady probably had a lumpectomy and had the lump removed, and now you can see at the bottom of the breast there's sort of an indentation, and probably if you feel that area, it'll feel like there's a little lump sitting there. Oh, sorry, this is another blurry photo, but that's quite a severe case. And then that's a really nasty case of a scar tissued breast. And here's another fact. Cording, which is also known as auxiliary web syndrome, and those of you who've seen a physiotherapist may have heard this before, can be a painful and debilitating form of fibrosis or scar tissue. And this is the scary part. It occurs in up to 86% of patients being treated for breast cancer. So again, these statistics come from the UK, but that's a really high percentage. And as I see patients, I can attest to the fact that even when it's very, very mild, we do see a lot of this. What is it? So cords are thought to be formed by the hardening of small veins or lymph vessels, and they occur most commonly between the armpits and the elbow. They can sometimes go all the way down to the hand and sometimes right into the side of the chest, down past the side of the breast. And they actually look like a little guitar string under your skin, and it pulls tight. And these can have a really profound impact on your ability to move your arm or to mobilize your shoulder, to just get to doing the things that ladies have to do. And patients with cording often describe that they have tightness. It can be quite sore, and it pulls in the armpits or the arm. And the ladies that are sent to me for rehab will often have very non-specific complaints. So they'll say, you know what, my arm is fine, but the moment I start to move or I try and stretch for my phone next to my bed, I feel this pulling in my arm. And when we have a look, we'll see that little guitar string that we look for. So it affects your mobility, and often it makes it difficult for you to lift your arm above your head. Sometimes cording mysteriously resolves, and the theory is that the cords become so hard that as you move, they actually snap, and the body then just reabsorbs them. But most often they'll need a little bit of help to actually resolve and get better. Okay, and that's a lady's arm, the armpit, and in the middle there you can see very fine lines, and those are the cords. That's a better picture. That's quite a severe cording, and you can see that it actually goes all the way down into her elbow. So this patient probably, she's probably really struggling with moving, with general day-to-day activities like brushing her hair or getting clothes out of the cupboard, and that's something we want to sort out. And there's another picture. This is an older patient, and she's got quite a thick cord, and again that causes quite a lot of discomfort. So the thing is that 1, 2, or a combination of all 3 of these have a compounding effect, and as a result, the cancer journey can become one of constant pain, of tiredness, of feeling that you have no strength in your arms. The arm is weak. It cannot do the things it used to do. Some of my patients will say they don't sleep well because the moment they turn on the arm, there's just this niggle. Something's not right. And then if you have a really swollen arm or cording, you'll have difficulty with mobility. It can affect exercising and day-to-day things. And in really severe cases, it'll make it difficult to function at home or at work. Some patients will simply say they have just regular discomforts, and we don't like that. To have regular discomfort, to constantly be in pain, that's not something that anyone wants, especially when you are currently in a journey that is already quite stressful, or you've just come through this journey and you're expecting to carry on with life. And so it's a really sad picture, and I love this little guy. This is Sadness from the movie Inside Out, and shame. So she feels really sad, and that's often what my patients look like when they come to me. They are really feeling hopeless because of this constant discomfort, this pain, and we're supposed to be getting back to life and getting on with things, but there's something stopping me. But there's hope, and it's the difference between black, white, and grey. I have a patient who explained it to me so nicely, and I don't know if she's listening. I didn't see her name, but I hope she doesn't mind me using her analogy. But her explanation was that the treatment of cancer is black and white. You have specific dates and specific treatment plans, and my radiation will start now and it will end on this date, and my chemo is going to be for this amount of weeks, and there's always a black and white beginning and end. But with rehabilitation, there's more of a gray area because of the mere fact that there is no exact science with rehab, because everyone's side effects are different. And so the question is, How do you get back your Mexican wave? And so I'd like to tell you all Layla's story. I thought the best way to explain how the rehab process works is in a story. So Layla is a patient of mine. She is a 52-year-old lady who was previously really active and on the go. She loved hiking and running. She had children in high school that she bussed around all day long. She still has. And then got this cancer diagnosis. So she had chemotherapy and had a lumpectomy with 2 nodes that were removed. And she was sent to me just after she had completed radiation, and came in to my office really looking like little sadness, saying, you know, I've completed this whole process and I was doing really well, but all of a sudden something's not right. I'm feeling stiff. My shoulder is sore. There's something pulling, and my clothes don't fit quite right. And so we brought Layla in and we did an assessment and found that Layla had quite a lot of fibrosis syndrome. So she had quite a lot of scar tissue at the area of the lumpectomy. She also then had a very thin, watery layer of fluid on her chest on the same side. And when we manipulated the arm, there were a few tiny little cords which were causing the pulling and the tightness. And then did measurements of both her arms, and Layla was extremely surprised to find out that the arm on the side of her treatment was actually 2 centimeters bigger than the arm on the other side. And so we started talking about treatment options for Layla. So I'm a very big believer that when we look at rehab, because it's a gray rather than a black and white, my patient and I are a team, and our treatment options need to fit in with both my needs and hers. So my needs are for her to walk out feeling great, and so are hers, but often life also needs to be taken into consideration. So the standard treatment for all of these symptoms are a combination of massages. We sometimes make use of laser. Internationally, a compression garment is still considered standard treatment. We also make use of bandages to help with swollen areas, and then there's a variety of other devices. In Layla's case, she said there was no way she was going to cope with bandages, and that's okay. She only had 2 centimeters of swelling, so we'll work around it. So Layla's treatment journey included a combination of massages. We did both lymphatic drainage massage, which is what we use to assist the lymphatic system to do its job of getting rid of the fluid. We then did a scar tissue massage and a deep tissue manipulation, and that's what we use in order to get the swelling, the scar tissue under control, and to minimize that. And then in a process of weeks, we managed to get Layla's fibrosis down to a point where she was feeling like her breast was again her own, and those are her words. And then with our drainage massage treatments, we got her arm to a point where it was the same as the other arm. Problem is, Layla then took a holiday. She had to travel for work, and we prepared her for that. But during that time, she wasn't able to quite self-manage as well as she had wanted to, and came back not feeling so hot. So things had gone backwards, the swelling had gotten a little bit worse, and we didn't panic, because there's no point in panicking. We're a team and we work together. And so we started some of the process again. And this time we added what we call a nighttime device. And this is a special, almost like a wetsuit that we put onto her for sleeping in, that helped to control the swelling. We then added in some low-level laser to assist with the cords that had started up again and again, the scar tissue. And that's when I discovered the importance of exercise. And so I always believe that you only know what you know. So we figured out that exercise was really going to make the difference. And so as a result, Layla got an exercise program that was both a stretch program and also a strengthening program, because at that stage she felt that her arm had lost a lot of its strength. And eventually we got back to the point where Layla could not see the difference between the affected and not affected arm, and she was brushing her hair and taking the kids to school and doing the cooking and all those things that she needed to do without feeling discomfort or pain. But Layla, like many of my other patients, couldn't visit me every week for the rest of her life, because life goes on. And so what we then started was self-maintenance. And self-maintenance is really important to me. My husband says he thinks I'm a decent therapist, but a terrible businesswoman, because I like to teach my patients how to look after themselves. And so self-maintenance in this case included continuing with quite a strict exercise program, continuing with her nighttime garment. And then, because she really didn't like having anything on her arm during the day, we did some trial and error, again, that gray area, and found the perfect point where the arm would stay the way we wanted it to, without her having to wear a compression garment all the time. And so Layla went on her way with her toolbox. The other thing that we include is something that they call dry brushing, which is a whole nother conversation, but basically she made a part of her daily routine, and every morning when she climbed in the shower, she brushed her arm so that it was ready for the day. Layla has now been with me for 5 years, and she pops in once every 6 months. She doesn't need me anymore. She's doing great. Her scar tissue has settled. She's in remission. And I think she just visits because I talk a lot and she enjoys my stories. But that's a really a good rehabilitation ending. And that's what we aim for in all our patients. I believe that if we work together, there's no reason why it shouldn't be that way for everyone. So I just like this one. I think it's quite funny. It says, this is Bill. Bill follows his home exercise program. Bill's mobility is improving. Bill is smart. Be like Bill. So as rehab therapists, we want everyone to be like Bill. And so there's quite a lot of research that looks at the impact of focused rehab during cancer treatments. And so one of the misconceptions is that rehabilitation only happens after the treatment of cancer. But more and more therapists around the world are realizing that treatment, rehabilitation during treatment has these really great results. And so these are some of the things that came out in studies. If we're doing regular rehab during treatments, we find that the patients don't lose their strength. They can actually continue with the exercise regimes or the usual tasks that they were doing before starting treatment. We find that patients' cardiovascular fitness maintains, and if someone wasn't very active before starting on this journey, it can actually improve. What they have found in studies is that the physical function of the patient maintains throughout the treatments and afterwards. And one of the things that we often hear is that throughout chemotherapy, it's very difficult to remain active. It's difficult to stay at work, stay in the job, keep up with the kids. And so a focused rehab treatment can help with those activity levels. And then what we've spoken about a lot tonight is that joint range of motion. So I don't want anyone reaching the end of their cancer journey and then realizing that they've got a problem in the shoulder, that the shoulder is not moving as it should. Some research suggests that the immune system functions better when you have a focused rehab program. Chemotherapy is more often completed on time when you're involved in a focused treatment program. And this one's my favorite. The last one's my favorite. The body image, the self-esteem, and the mood. And when you are having treatment for breast cancer, there's and I'm not the psychologist, so I'm not the expert here, but there's so many thoughts and so many emotions. So if a good rehab program can keep you feeling good about who you are, what's better than that? And then they've looked at some reductions. In one of the studies I looked at, patients reported that they had a reduction in nausea and tiredness, reductions in pain. I see firsthand. There's a reduction in the intensity of side effects. Again, this isn't my study, but there's a study out of the UK that says that patients who are receiving regular rehab actually see a reduction in the amount of times they end up in hospital. Psychological stress is better if you're remaining active through your rehab program, emotional distress, and then depression and anxiety. So, and I say in conclusion, but I wanted to leave time for questions because as I said at the beginning, I like to be interactive. But let's conclude and say that while rehabilitation from the side effects of breast cancer treatment is not always that simple black and white process. And simple is not the right word. I should take it out there, because cancer treatment is never simple. But the effective rehab can really decrease the effects of swelling, long-term swelling, and scar tissue, and it will work. We aim to work with the patients, and then in the end to bring back and to keep your Mexican wave. And then just to end off, we're really excited that on the 7th to the 13th of September this year, we will be celebrating our first International Cancer Rehabilitation Awareness Week. And I think this is something that would be nice if we can all celebrate. And there we go. Are there any questions?
Thank you very much. Thank you, Jen. It was a good review, and I think people tend to focus so much on the cancer treatment part that people tend to forget about the rehab part of it. Maybe just stop your screen share for me if you don't mind.
It's not stopped. Stops now.
Yeah, there we go. All right. Anyone that has a question, you're welcome to unmute your mic and ask your question, or if you want to, obviously in the chat, you can leave like we usually do, just leave your chat there. So Lelani asks, how long after radiation can you still have rehab for painful scar tissue?
So Lelani and Dr. Myberg might have more scientific answer, but scar tissue can continue to actually grow for up to 2 years after radiation. So we'll try and prevent that growing for the 2 years, but scar tissue can be broken down at any time. So you can come and see a rehab therapist 20, 30 years after your treatment. It's harder work for me and for the patient, but we can continue working on breaking down scar tissue at any point.
Yeah, maybe just to add to that, I think in the past, the idea was that you would then, would do your operation, you would do your radiation, and, when you then finished, then you go and you send the patient to the physiotherapist or to the rehab specialist. And the issue was that, unfortunately, by then, a lot of that scar tissue had become sort of fixed and very difficult to deal with. So I think the trend is shifting to say that you should really, actually start your rehab process already sort of before you start your treatment. So the therapist should evaluate the patient beforehand to see what are the limitations that the patient already have. Lots of our older patients already have rotator cuff issues and stuff like that. They should be part of the planning of the treatment in terms of these are the things that we need to watch out for and interventions that we need to plan as part of our treatment. And then I think the other issue is when you do treatment like radiation, for example, in the beginning when you do radiotherapy, you end up with an inflammatory type of response to a certain extent. There's almost an increased blood supply to that area, and certainly sort of up to about 4 to 6 weeks after the radiotherapy, you almost have an increased blood supply to that area. And then only after that you start going into that sort of phase where you have scar tissue forming, we call fibrosis, and the blood supply actually starts going down. And that's the phase that it now becomes more difficult. So the ideal is that you should really want to get in there quite early and look at what the patient's situation is. I mean, we do fat grafting where we go and harvest healthy fat cells from outside of the cancer area, and we inject that fat cells back into that breast so that we take healthy cells and put it back into the radiation area. And we try and aim for that window sort of between 4 and 6 weeks afterwards. So it's a combined effort. Try and get good gains early on and not wait until things are sort of fixed before you then sort of start having a problem.
Yeah.
There was a question, I think, from Genevieve that said, how soon after radiation can I return to my physiotherapist?
Yeah. So I must be honest that there are different oncologists do have different opinions, but the international standards and the rehab standards internationally are that you can have lymphatic treatment and scar tissue treatment throughout your radiation. So you do not have to stop seeing your physiotherapist at any point. As well as exercise and movement. It's essentially important. So my opinion is that you don't have to wait at all or take any time off during radiation from your treatment protocol.
Yeah, and I think that answers Genevieve's second question, whether she can continue with dry brushing and lymph massage while receiving radiotherapy. So I think that answers that question. So maybe, Andre, the issue is, I mean, lots of people will say, listen, while you're having radiation, you're not allowed to put anything on the breast, and they, use the all kinds of Mazina and things like that. So my question now is, from a radiation oncologist point of view, how soon can one start treating that breast after the patient's had radiation, and why do we have to be so careful about this?
How soon after radiation can you start with the massage?
That you can actually start treating the breast or the radiation area specifically. And I think my question is, why can't you continue? Why can't you be massaging the breast and rubbing it with all kinds of oils and creams while the patient's busy with radiation?
Well, on radiation itself, the epidermal, this outer skin layer turnover is hampered by the radiation. Different patients have different skin reactions, but especially the connection between the dermis and the epidermis becomes more, I almost want to say, more friable, and any excess rubbing or manhandling of the area can lead to almost like sloughing or the skin coming off. Obviously, if you are on radiation and you have a lymph therapist, someone that's trained in that area to guide you through the process, I would say that's something you can do. But while someone is on treatment and they might not necessarily have access to a trained professional in the massage world or lymphatic specialist, I would usually avoid. I usually caution them.
Yeah. Jane, you want to add anything?
Yeah. So I wouldn't. I would definitely avoid dry brushing of an area receiving radiation. Dry brushing can be a little bit more aggressive, but I've been seeing patients throughout radiation for a number of years, and touch wood, I've never experienced that we have a problem. In fact, the process of lymphatic drainage actually assists with the side effects of the radiation. So as long as it's done in a proper way and by someone who knows what they're doing, I think it can continue throughout radiation.
Yeah, and I think, again, that's the importance, of, for the same reason that you cannot expect the same level of care or the same operation if you go to let's say, a doctor that does, 500 gallbladder operations a year and he does 5, mastectomies a year. You're not going to have the same level of surgical care than what you would have if you go to a doctor that does 500 breast cancers a year. The same thing with your therapist. So the physio that does mainly sports injuries and shoulder injuries and all kinds of things, and then all of a sudden has to treat the breast cancer patient, is not going to have the same level of knowledge, the same level of professional interaction as someone that is dedicated to doing lymph therapy and sort of doing oncology related treatment. So I think it is important to find a person that is really, in the game, if I can put it that way. Lindy says we've got the 29 radiation sessions after double mastectomy and direct implants in December. My affected breast feel very stiff and swollen but bigger. I was not aware that I should get treatment. Thought it would just get better by itself, just rubbing myself with arnica oil. Query the correct person to go and see. And Carla also asked whether patients with implants have a different radiation protocol. So maybe, let's say, two different questions, maybe a little bit. Lindy, I'm not sure which region you are from. Are you from Cape Town or are you from a different region in the country?
So,
Hi, no, I'm from Johannesburg. I'm with Professor and Ben.
Okay. And do they not have a rehab team that works with him, with Carol being?
Yes, so at the moment, I had cancer last year and I was in remission and clean. 4 months afterwards, I got cancer again under my arm lymph node. So I just knew I had a cording because the vein was, you could clearly see it till here. And then my oncologist suggested I do like when you shower and you rub your back like this. And a week ago, it just disappeared. So that's gone. But my breast itself, I don't know. So I heard that it takes about 2 years for your breast to heal inside. So I just thought this is it. So should it be treated then now? Because it's definitely hard. Yeah.
So Lenny, I think from my perspective, anything that's causing you discomfort, I think you deserve to at least have someone who knows what they're talking about have a look at it. A lot of these things do resolve after a period, but if there is something else going on, I would suggest get someone to have a look at it and give you a professional opinion. From a rehab perspective, there is the Lymphedema Association has a website, and there's only about 120 of us who are registered in the country, but we're all on that website, and so you can find the contact information of someone who is certified and trained and may be able to give you a better a better path forward.
Maybe just to add, Lindy, so I've posted the website. It's laosa, LAOSA. .co.za, and they do have sort of a find a therapist function on there that you can use. I do think just to link on to what Carla asked as well is patients with radiation after mastectomy, especially if you've had a reconstruction, there can be several different reasons why the breast could be swollen. So there's a difference between someone who has who has swelling of the skin and the tissue. We do see patients that sometimes have fluid developing around that prosthesis. We get a concept sort of a chronic seroma or a chronic hematoma. I have had a few, I've had a few patients, fortunately very few, that have developed almost like an infection picture a couple of months after the radiation, and to the extent that we had to go and remove the prosthesis. So I do feel if someone has, if you've had a mastectomy with reconstruction and you've had radiation and that breast remains really swollen, and then I think it's important to answer the question is where is this, where the swelling is coming from and how do we manage that? And I think that's something that your care team, so your Dr. Ben and her team should evaluate that first and make sure that it's not a surgical complication or a radiation related complication, and then say, all right, listen, this is lymphedema of the skin, let's get a therapist involved to help with that. But I think that is an important, it's a multidisciplinary way of dealing with that.
Yeah.
Carla asked whether we changed the radiation planning for patients with prosthesis, and I think, Carla, the reality is, let's say over the last, I don't even say 15 years, but even in the last 10 years, we've definitely changed the radiation options for patients and the radiation planning for patients. And in principle, it depends. Number one is whether, what your cancer entailed. If someone has a very small cancer, very limited cancer, you're going to do a different approach to someone that had quite an extensive cancer. And I think the big question is, do you need to radiate the chest wall, which means that you have to radiate the muscle and the rib part of it behind the prosthesis? Or do you really just want to irradiate that layer of tissue that is actually in front of the prosthesis? So, and that does make quite a bigger difference. We are trying, I think, more and more so, even in the last, short term, we are trying to sort of individualize the radiation planning for patients to fit with what they need. I always ask the question, what is the target and what do we want to achieve with this? So you radiate patients for different reasons. So not everybody should get exactly the same thing. What we do see, though, is that if you are someone whose tissues react a little bit more aggressively to radiation, if you then have a prosthesis in there, the tissue is going to contract around that prosthesis much more so than someone who doesn't have a prosthesis. It will still contract, but there's nothing to contract around. So, but because someone then has a prosthesis, it's going to feel like that prosthesis has become harder and sort of more compact. And we call that capsular formation. We know that probably about 20% of patients, if they've had radiation, will have quite significant capsular formation, but it doesn't mean that there's nothing we can do. So, we'll often go back and do capsulectomies, add, lipofilling, stuff like that. So I think, again, even in the last 2 or 3 years, there's been several new additions to what we can do. The issue of cording, I think, is something that is, when you do an operation under the armpit and you excise tissue there, the little veins draining into that area are going to be disrupted, and they are going to close up and form scar tissue. So in a certain sense, it doesn't matter where in your body you do an operation, you're also always going to cause a little bit of that. In most patients' cases, it is just one of the reasons why they will have pulling. And yes, I agree with what Lindy said, is that just with normal sort of exercising and stretching, in a lot of patients, that will actually go away. We do see some patients that require a little bit more intervention, and even some patients where you have to go with a needle through the skin and actually sort of cut through that little cord just to sort of release it. But my experience is with non-invasive interventions, with massage and stretching and deep tissue manipulation, people like Jen and them can really get those cords away without needing any surgical intervention. There was, let's see, there's one question. My question is a bit of off topic. I have completed chemotherapy mid-May and radiation mid-July, but my immunity is still very low, and I'm still getting Herceptin injections. Is there anything I can do to improve that? Andre?
Well, I would like to, clarify. If you say your immunity is low, is it something that's still clinically discernible? Meaning, is it like immunity that you can actually see neutropenia still on a low blood count, or is it just that you are really prone to infections despite having a normal full blood count?
Maybe Sarameen, do you want to unmute yourself and maybe just tell us what okay, you're talking full blood count. Do you want to unmute yourself and just give us some sort of idea of what your blood counts look like?
Yeah, my white blood cell count is 2.5 and my neutrophils 0.9 2 weeks ago. So I get yeah, so it's quite low still. And my oncologist said that she suspects it's got to do with Herceptin. But obviously with the COVID-19 pandemic, I've been isolated in my house for months now.
Yeah.
So, yeah.
So I mean, I assume if I assume you're at the full, AC followed by paclitaxel. Not that I want to go into the full, medical conversation. I mean, you also have to remember that if you've had the full course, that even if you finish the chemo mid-July and we are, not even, well, almost mid-August, a lot of patients have bone marrow fatigue, and I think you just have to be patient. I find especially the last few cycles, especially if they get weekly paclitaxel, patients struggle to get through it, and you just have to be patient. It is going to get up. I think the Herceptin has less to do with it than you would think. Yes, I know it plays a role, but it wouldn't prompt me to change anything about the Herceptin dosage. It wouldn't prompt me to delay any of it, because I mean we want to keep on doing it. We know the importance of Herceptin. Focus on, I would ask, is your vitamin D supplementation on par? Is your magnesium supplementation where it should be? Are you taking your B complex vitamins? I would say especially vitamin D and magnesium, because you can test for it. We know the importance in terms of immune modulation when it comes to vitamin D. So that's definitely one thing to look into if your oncologist is maybe not checking on it. That's one thing I would add.
So maybe just from my side, I want to say, so remember, often patients will come and say, they want to take an immune booster. And I mean, even here in Cape Town, you listen on the radio station and they, Bobby van Jaarsveld vertel van die druppels wat hy gebruik and whatever, So the issue is people have this misconception that we have this sort of magic whatever, supplement that we can do that's an immune booster. Now, your body's immune system consists basically of two big things. The one is your cellular immune system, that is your white cells. They are mainly there, they fight mainly bacterial infections to a large extent. And then you have antibodies, and that's the stuff that will, I always say it's like the little heat-seeking missiles that will go and find, but an antibody needs to know already what it's looking for. So that's why we immunize, against measles and stuff like that, so that your body already knows what a measles virus looks like, and when the virus arrives, it can kill the virus before it makes you sick. And it would be the same with a COVID vaccine, for example. We want to train your body to know in advance what this virus looks like, so when it attacks you, it doesn't have a chance to actually do something. Now, so the first thing I want to say is when your white cells are low, like with chemotherapy, currently we have no evidence from literature that suggests that these patients are at an increased risk of getting COVID virus infection. So I think that's the first thing. The second thing is there's also not really good evidence that says if someone's white cells are low and they do get COVID, that they're going to land up in ICU. We've had several patients that tested COVID positive and they've all actually been either asymptomatic or fine. The thing that it does increase your risk for is having bacterial infections. Things, even a simple infection like a skin infection or a tummy bug or a bit of bronchitis can make you severely ill without giving you high fevers and things like that. So I think that's the thing. Now, you don't have zero white cells, so it means that you're not in that very, very high risk category, but it does mean that you are at an increased risk. The question I always ask, and that we often see with our patients, I'll sometimes see the patient even 2 or 3 years down the line, the white cell count is like 2.8 or 3, but when they do get an infection, that white cell jumps up to 12. So it means that the bone marrow is a bit lazy, but it does respond appropriately when something attacks or happens. There's nothing specific that you can take that's going to make your bone marrow start producing these extra white cells. Time, I think, is the big issue. I agree. In general, there's lots of evidence around vitamin D, and we know that at least 20% of women in South Africa have a low vitamin D count. So in theory, I think every woman who's had breast cancer should probably be on a vitamin D supplement. Depending on your health otherwise, you might need a few other things like magnesium, especially if you've been through quite a hectic period of treatment. So I think the issue is one probably need to give it a little bit more time. There's nothing you can do that's going to rush it along and make your bone marrow recover. In principle, if someone's white cell remains very low for a long period of time, we would definitely do a bone marrow biopsy, but it's still a little bit short, I think, with that. And I'm fairly sure your oncologist will keep on monitoring that count without now being overly concerned at the moment. So I think it's fine to trust the oncologist to keep an eye on that, and maybe in the interim, what you can do is maybe some vitamin D supplements, for example. Genevieve said, can I continue taking my zinc sulfate and calcium supplements during my radiation? What are the chances of rib fractures during radiation?
Very small.
So the risk is really small, I agree, and I think none of those two things will interfere. The things that will interfere with radiation is if you take heavy antioxidants. Antioxidants will diminish the effect of the radiation, not only on the tissue, but also on the cancer cells. So while we're doing radiation, you don't want to do lots of like high dose vitamin C, vitamin A, vitamin E, those type of things. Watch out for that. But the like calcium and zinc and those type of supplements are fine to continue probably. Anita is asking, I was taking Neofidin, but it was soon after lockdown, out of stock. Ja, nee, ek kry elke dag 'n oproep daaroor. Now out of stock with Tamaplex. So yes, Anita, the problem is that part of lockdown is that we, remember that we're not the only country in the world with COVID, and all of these drugs are being imported from other countries, and I think the problem we're facing is imports. So currently, my patients are sort of looking around. In principle, there are four. The Neofidin, the Kesar, Tamaplex, Nolvadex is sort of the original one. They're quite expensive, but there are at least 4, and I know there are at least 2 other generics that are not as frequently found. There are, in other words, lots of different ones. So the bigger pharmacy groups generally do have either one of those 4. And for me, if it's a choice between, no, I only take Kesar and I don't want to take something else, versus someone that says, I'll take any tamoxifen as long as it's got tamoxifen in it, then you take any one of them. That's my advice. If we really run out of tamoxifen completely, we'll have to look at different plans, and that's now obviously going to be out of the box thinking. I'm hoping we're not going to get there. And Anita says, I am also forced to take Tamaplex now, yeah. So I really don't want you, tamoxifen is not a difficult molecule. It's not something that needs a lot of, that's affected by absorption and by, complex processes. So lots of companies can make tamoxifen, and you can be happy that the same amount of tamoxifen is in all those tablets. So you can continue to take any of the brands. Rather do that than not take anything. I think that's the short answer. Maybe any last questions from anyone? Genevieve, is Neerlinks available? It's better than Herceptin. Genevieve, are they giving you the subcutaneous Herceptin, or are they giving you the intravenous Herceptin? Because I think the issue, so let me put it this way, is Herceptin is the trade name for trastuzumab, and in principle we have several different anti-HER2 drugs that we can use. But at this stage, with, I want to say, the run-of-the-mill HER2-positive breast cancer, if you respond well to Herceptin, you have to always weigh up the cost of adding something else. So the issue is, I wouldn't use anything else at this stage in the standard adjuvant setting. There are a few patients that ideally would want to have sort of a double anti-HER2 treatment, but the problem is at this stage that it's still very expensive and lots of medical aids are not covering that. So, and the reality is that the extra benefit you gain is not really worth the effort. So I think if you only have 9 left, it means you're fairly well down the line. I don't know, Nerlix, or I'm not sure what it is exactly. It's not a name.
It's neratinib. It's I wasn't familiar with the trade name.
Yeah. The small molecules in general, let me maybe just put it this way, and it's like the same like lapatinib and neratinib. They do not have the same advantage as something like, for example, Herceptin. So at this stage, the data is certainly not that I would replace the one with the other. Not in a curable patient. I think that's the bottom line. I think we've covered all the questions on the chat. Is there anyone that wants to sort of add some last words or share anything? You're quite happy. I'm quite happy for you to unmute your microphone and just give us a shout. Or if Marlize or Jen wants to add anything sort of as a final note. All right. So I hope you enjoyed the talk tonight. Again, we're trying to sort of keep these meetings at about every 3 weeks for the time being. We're very happy for you to send us some suggestions about topics that we should talk about. And I want to please say, if remember, this group is not patients that are our patients only. This group is available for breast cancer and breast cancer related patients, I want to say, all over the world. So if you know someone that you feel like would want to join in and want to share whatever, I'm very happy. You can send us an email through the webpage, leave a note on the Facebook page. Tonight's meeting have been streamed live on YouTube, so that's the first for us. I hope that's been successful. So you can comment below on the YouTube channel as well, and we'll get those comments and we'll get those suggestions. So, but other than that, I hope you have a wonderful evening. Thank you for everyone tuning in. Dankie Jen vir jou praatjie wat jy vir ons gegee het. I hope you have a wonderful week. Ding is, ek sou kyk, kom ons stop gou die stream.